Good evening and welcome. I think we'll go ahead and get started. We may have a few straggle in here in just a minute. They're still eating the delicious hors d'oeuvres out there. A couple reminders. If you could please, if you haven't already signed up or signed in sometime before you leave this evening, if you could sign the sheet in, I think it's in the back of the room, just so that we can note who's here to use for some of our grant counting purposes. Another thing they left in the back is a little pamphlet on some of the online offerings for evidence-based medicine that have been provided to you. Again, all of this initiative came out of the R25 grant, which was looking at evidence-based medicine and how to better integrate it into our curriculum and our training and throughout our institution. So I do want to thank tonight the grants and sponsored projects staff who made all this possible tonight and helped get everything together. But it's my great pleasure this evening to introduce our guest speaker, Dr. Alan Shaughnessy. Dr. Shaughnessy is a PharmD and has a master's in medical education. He's a professor in family medicine at Tufts University School of Medicine and director of their master teacher fellowship. He's been there and taught in the family medicine residency program for many years. He received his doctor of pharmacy degree from the Medical University of South Carolina and his master's in medical education from the University of Dundee, Scotland, which we talked about earlier. A really great place to get educated from. He's been completed a faculty development fellowship in the federal government's Department of Health and Human Services Primary Care Health Policy Fellowship. And he's a board certified pharmacotherapy specialist and a fellow of the American College of Clinical Pharmacy. You know what, I'd like to go off script because you can all read his bio here, but Dr. Shaughnessy, I hear him call himself an early adopter. When you talk about EBM, he said he's one of the early adopters, but I would take that a whole lot further and say he is a pioneer and the guru of evidence-based medicine practice and education in this country, and has done a tremendous job. I know he's worked with the Tufts course with Dr. Slauson for many, many decades, and has really been a leader in the healthcare professions in terms of providing information and teaching the rest of us. So we're very honored to have him here this evening to speak on the topic. So thank you, Dr. Shaughnessy.
Thank you. Yep. There. Thank you. Well, thank you for that introduction, and I'm very pleased to be here. This is not telling you anything, but I had to get up at 5:30 this morning to get here. So it's a long way from Boston in lots of ways. Left a long winter there. Left this little problem we're having currently talking about. You've probably heard about it, the little problem with atmospheric pressure in various balls that are involved in Super Bowls and stuff like that. We're trying to explain that anomaly to ourselves in a way that doesn't get our golden boy suspended for several games. Anyway, I wanted to mention to you, I have the yearbook from 1939, just to give you a little background. My first name obviously is Alan. My grandfather was named Charles Allen, and his brother was named Paul Allen, and Paul Allen was a class of 39 here at A.T. Still, and I am named Allen because of the two brothers. Neither one had sons, they just had daughters. So the Allen lineage in our little corner of the world disappeared, but to keep the lineage going in some little sort of symbolic fashion, my mom insisted, probably my grandmother had something to do with it too, that I'd be named Alan. So anyway, so I have a little bit of a tie to A.T. Still because of my pseudo-alumni status. Anyway, I'll take credit today only. So what I'm going to talk about today is talk about some of the ideas about what we call information mastery, and talk about the idea of how to make decisions. Now, decisions in medicine is a knowledge business. And part of that knowledge, or part of what we do, is manage knowledge through the making of decisions. Medicine or healthcare as an industry is coming under a lot of sort of external fire. You know, for years we were able to sort of do things on our own, and whatever we said was good was good. But now there's lots of people looking at the healthcare industry and saying, hey, wait a minute, you're getting too expensive, the quality's not where it should be. And as you all know, anybody in practice, you know, there's lots of people out there willing to tell us how it needs to be fixed. From managed care organizations to health insurance to the government to all sorts of people. Now I want to talk about a little bit about, to sort of contextualize what I'm going to talk about, I want to talk about this idea of what we need to provide to society. You know, society grants healthcare, grants medicine, basically say, you run the show, and as long as you do a good job of it. And if you don't, we're going to come in and suggest to you other ways to do it. Now, so our goal always has been, maybe implicitly, now it's getting very explicit, is that we have to provide high value care. Care that, and I've got the equation here of what I mean by value. Value is quality, meaning our outcomes, safety, our service that we provide divided by cost. So as costs go up, value go down. As quality goes up, value goes up. So what we want to do in medicine, this is just obvious, I'm just setting the stage, there's no brilliance here. We want to provide the best possible care without unnecessary costs. Now there's lots of ways to do this. If we look at, some of you may have seen this, image before, it's the idea of process complexity. We are in a business that has simple aspects to it, complicated aspects, complex aspects to it, and chaotic aspects to it. Now I'll just quickly go through these ideas. So at the very bottom here is simple. Simple means there are simple decisions that can be made that most people would make the same decisions, and everybody would agree to that. Now complicated are decisions or processes that occur that have various steps to them, but they also can be sort of written out and followed, and anybody can follow them. They're sort of an algorithmic approach. Then there's the complex. And you who practice deal with the complex all the time. The patients who don't fit, that have enough combinations of uniqueness that they don't fit any special algorithm, yet we're still trying to push them into an algorithm. And then there's the chaotic, which is when people don't read the book and we think something should happen and it doesn't happen, and it's totally out of control. Now, as we look at try to improve value in medicine, the first thing we've tried to do is we've tried to address the simple, the low-hanging fruit in medicine, to try to increase value and increase quality and decrease costs. And this has been to standardize practices through teams, to move the repetitive non-cognitive tasks away from physicians and get somebody else to do this. So you probably all are doing this. This is certainly what we're doing with teams, and having MAs do this and various other people do other things. But that's the low-hanging fruit. And you can get some small gains in value there. You can get them quickly there. The second wave is to get the complicated addressed, and these are through good practices. And this is standardization. This is the checkbox manifesto of Atul Gawande. This is the idea that we will try to get everybody doing pretty much the same things for things that can be done in the same way. So we develop local guidelines or various things. This allows us to standardize practices for the big decisions. But medicine is made up of countless little small decisions that can have a dramatic effect on value. And that's the third where. That's where we get into the zone of complexity. And that's where we want to help physicians to make decisions better. So the first two things that I talked about are process changes. We can get the MA to take off the patient's shoes and so that we remember to check this, and we can document this and that and all this sort of thing. That's all process stuff. But when it comes down to dealing with complex patients who are not the same as any, that don't exactly fit into any guideline or pathway, we have to talk about individual patient or physician decisions. And to do this, we have to change the process of thinking. And that's what I'm going to talk about today a little bit, give you some ideas that come out of some of the stuff that I've been working with for a long time and Dave Slauson has been working with to change people's thinking process. These are the concepts of evidence-based medicine or evidence-informed decision-making. That's what I'll be talking about today. The concepts of information mastery, which I'm going to go through, helps to support this. We're going to talk about how decisions are made and how the decision-making process can go wrong. And then eventually the idea here, and I think this is part of your R25 grant, was to really change the whole culture of how people think about things around here. At least that's what we try to do in our practices, is change the culture to a shared understanding that involves the use of the best evidence. Now, this will be related, I promise you. This will be related in just a minute. But I want to just take a poll and just ask, according to traditional stories, how many antelopes did Noah take into the ark? So I don't want anybody to Wikipedia this. Just tell me. Who says one? No ones. Twos? Got lots of twos. 5, 7. Got 1 7. 14. Got 2 14s. And for the group that's watching, I'll just take it for granted that you are raising your hands out there. Okay, let's go to the evidence. This is what Genesis says. Of every clean beast thou shalt take to thee by sevens, the male and his female. The idea of sevens probably means 14, so the two of you said 14. I would give you get full credit for that answer. The male and his female and the beasts that are not clean by two, etc., 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 etc. So that's what it says in Genesis. Maybe somebody else has better evidence. That's the evidence I got. Now, I use this to illustrate how do we make decisions. So where'd you get that information to make that snap decision? Almost all of you, except I think 3 people, said 2. Where'd you get that information? You just knew it, right? Except you didn't, because it was wrong.
It was on your slide.
It was on my slide. That was a little tricky, huh? Yeah. It probably wasn't on my slide. You learned it in Sunday school, you learned the song. It just, as far as you know, is written in the Bible, except it's not. That's what we're talking about. If you had the time and the interest, what would you have done to make sure that you had the right answer? Well, you might have looked it up. But you still probably would have said, I just know that. I don't need to look it up. And that's what we have. This is the metaphor for what we have in medicine, is there's a 2-step process here. One is deciding if what you know is really so, and then the second is going to find the answer if you're in doubt. So let's talk about evidence and decision making. No one has time to appraise all the evidence. I think if we added, when I use the royal we, I'm talking about my colleague and I, Dave Slauson. He's at the University of Virginia. We do just about everything together as far as this little realm of the world. If we added anything to the world of evidence-based medicine, we started talking about the ideas that most is this idea right here. Nobody has time to appraise all the evidence, to look at the original research and digest it and decide if it's true or not and put it into practice. If you did that, you actually wouldn't have time to practice. So we're not talking about what I call furrowed brow evidence-based medicine, which is when we work really hard you've all been in some sort of journal club or something like that. We work really hard for an hour dissecting an article and then go back to what we normally do. Anyway, where do most people get information on which to make decisions or make new decisions? We use either brief reading or talking to other people, main sources of information. And most decisions are based, like Noah's Ark, based on what we think is the evidence, not what we know is the evidence. And again, that's because we can't all spend all of our time making sure that everything we think is so is so. So evidence in the practice, there must be something more. This is a classic cartoon. You can see there's a long equation here, and then in the center it says, then a miracle occurs, and then the rest of the equation. And at the bottom it says, I think you should be more explicit here in step 2. We have to figure out why evidence doesn't get into practice a little bit more, and it can't just be based on a miracle. And so what I'm going to be talking about, the something more, is the concept of clinical decision making and how it's not about evidence and it's not about information. It's about making good decisions. And some of this idea that I'm going to talk about now for the next 5 minutes is based on this book by Daniel Kahneman. He originated some of these ideas and incorporated people's other ideas, but it's the idea that we think in two different ways, in a fast mode and a slow mode. So to illustrate this, I'd like you to get out a paper and pencil. You've got paper and pen in front of all of you. Those of you who are watching, you can do this too. You may not be as prepared. I'll give you a moment. But what you basically need to do is I'm going to ask you 6 questions. These are not going to be handed in. These are not part of the grading system here. If we were going to grade your participation tonight, it's not part of the grant. It's just to illustrate the idea. So I'm going to ask you 6 questions. Are you all ready? 1, 2, 3, 4, 5, 6? Okay. Question 1. On a standard Boston fire truck, there are 2 drivers up front, 1 at the rear, just one of those cool ones in the back, and 4 additional firefighters hanging on. What is the total personnel required for 5 standard trucks? 2 up front, 1 in the rear, 4 hanging on. How many do you need for 5? Okay, got it? How many turtle doves did my true love send me on the 2nd day of Christmas? Okay, good. The average time required to paint a room is 4.5 hours. How much time should be allowed to paint 3 rooms? Question number 4. A bat and a ball cost $1.10 in total. The bat costs $1 more than the ball. How much does the ball cost? Didn't know there was going to be a test, huh? You thought it'd just be hors d'oeuvres. Got to work for the hors d'oeuvres. If it takes 5 machines 5 minutes to make 5 widgets, how much time does it take 100 machines to make 100 widgets? Only one more question. And in a lake, there's a patch of lily pads. Every day the patch doubles in size. If it takes 48 days for the patch to cover the entire lake, how long would it take for the patch to cover half the lake? I swear this was happening in the Boy Scout camp that I went to, the pond every day. We went out and there's more lilies. Okay, so here are the answers. Check your work. 35 firefighters. 2 turtle doves, 13.5 hours. $1.05 is the cost of the bat. 5 minutes and 47 days. Now, the first, I have them separated like this because the first 3 are basic algebra, basic things you just recall, the 2 turtle doves. Sorry, I can't remember if I asked you for the cost of the bat or the ball. The ball is 5 cents, the bat is $1.05. The first, this takes a little bit of, you have to carry the 1 for the 13.5 hours. That's not so hard. Most people get 1 or more of the second group wrong. And it's because the standard way that you would approach them, and the standard way you approach the first 3 questions, doesn't work. And the second problem is you have to know that it's not going to work. So you have to switch into a new mode of thinking. Most of you probably said ball costs 10 cents or bat costs $1. You probably said 100 minutes instead of 5. And you probably said, what did I say? 24 days for the bat. Because that would make sense, except that it's wrong. And the reason why I point this out, well, first of all, just let me relieve your anxiety. This is a standard test of cognitive bias, not brain ability, just cognitive biases that we all have. It's done in a lot of places. You can see at MIT, they got 2 out of 3 right on average, all the way down to the University of Toledo. Not so good. We obviously have some party schools down here. Anyway, just letting you know, this would be typical. If you didn't get all of them right, we wouldn't expect you to. Because they require those two things, knowing that you need to do something different and then being able to do it. When you actually knew you needed to do it, it wouldn't be that hard. It's just the knowing. Let's do it again. Let's do it in medicine now. Well, sort of in medicine. Tell me what, out loud, what you see in the next slide. And the people who are watching this, you can do this in your own room. I trust you. Just yell it out. Ronald Reagan. Shingles? Zoster? Now, these two, what happened here? Did anybody say, okay, got black hair, winning smile, wise eyes? No, you just said, bam, Ronald Reagan, right? You didn't say, oh, I don't know, it's either Reagan or Clinton, right? I know it's a president. You didn't do that. Let me see, Washington, no. Lincoln, no. Garfield, no. No, you said, bam. Instant pattern recognition. Same thing here. A lot of primary care people in the group, because I do this with other groups, they say, some sort of rash, I don't know. Okay, now, what do you see on the next slide? Central America. Never heard of that one before. Okay, so imagine you're all back the first days of school, medical school. You would have a class, and you would learn how to diagnose this. I'm going to teach you how to diagnose cows, because this is a cow. All right, so what do? We start with the prototype of a cow. This is a cow. It's got wide set ears, wide set nose, a big nostril that looks like that. Okay, that's what a cow is. When you see a cow, it's going to have these characteristics: the wide set eyes, the ears that stick out, and this broad snouty thing. You guys know a lot more about cows, probably. You don't have to call it a snouty thing, but I actually grew up in dairy farm country in Pennsylvania, where we had more cows than people, but nobody ever gave me they just said that's a cow. They never broke it down for me. But when you start any type of new teaching, you have to take the prototype and explain to people what they're seeing. Okay, so that's a cow. All right, now here is another variation of a cow. It's a little more complicated now, but you still see the characteristic: 2 ears. You can make sense that there might be an eye there, and you see the big snout or snouty thing. So, okay, so now you're starting to get a little bit more sophisticated with your pattern recognition. Now I got to give you some other clues. All right, just like zoster, there's some times where you see cows in other places you would never expect to see a cow. So if you see something that's in the water with that long snouty thing and the wide set eyes, it's not a cow, because cows are never in the water. Okay, so good. All right, so you got those 3. Now I'm giving you some characteristics. Okay, so now you go back to this picture, and you can kind of make out a cow. I see that. Oh, yeah. I can make some sense out of the nose. We don't have great lighting here, but you can start to see it now, right? Yeah. You see some cowness. Yeah. Yeah. This is pattern recognition. Now I got just a little aside. I gave this lecture. So I'm at the New York College of Optometry, and I give this picture, and I say, "What's that?" And they all say, "It's a cow." I said, "How did you know that?" See the eye? No. They all said it's a cow. I said, "How did you know that?" Because nobody ever knows it. And they said, we use this to teach. Because one of the things they do is they teach not only refraction, but visual processing. How does the brain put together images? I'm talking about pattern recognition. They're talking about what is the processing that occurs. So they all use that. They didn't use this picture, but they use this idea. Okay? So what I've been trying to do is highlight some cognitive biases that we all have. The several examples I've been talking about, from the 2x2, animals going 2x2 is a cognitive bias that we didn't even know we had. It was from early learning, the idea of being able to switch from 1 to 2. There's all sorts of cognitive biases. Now, these are not character defects. These are what we all do. All of us, all humankind do these. These are common things that happen, and we have to, and we do them because they work very well. They get us through our day by working just fine. What do we say? If it walks like a duck and looks like a duck, it's probably a duck. That's a heuristic. That's a rule of thumb. When you hear hoofbeats, don't think of zebras, think of the common things. That is a heuristic, that is a cognitive bias that serves us very well, except when it doesn't. And that's what we're talking about, is figuring out when our inherent heuristics or cognitive biases that help us get through the day just very well no longer are helpful. Now, this is to remind me to tell you about a project that my colleague Dave and I have been working with in the United Kingdom. They're very interested in this, because if you don't listen to international, you think we have it bad. The National Health Service is limping along on a crutch, and that crutch is getting kind of rickety. They are saying we need, they only spend half the money on health care that we do, but they're saying it's still too much. And David Cameron, just re-elected Conservative, he's saying, no, we got to cut it even more. So they're saying, okay, well, we've been trying to use evidence-based medicine for the last 25 years and it's not working, so we got to do something else. So we've been part of this project that resulted in this documentary called Making Decisions Better, which is the part of the title of my talk. And we're part of an international group of people, and one of the ideas we came up with is a mnemonic called RIDE. And RIDE stands for right system at the right time, implementing the best evidence, dampening down your biases, and explaining and sharing with patients. So I'll just go through this very quickly. So what I've been talking about, this idea with Daniel Kahneman, and this idea that we need to switch our way of thinking, is the idea of what's called dual process theory, that we think in two different ways. We have the intuitive system, what Kahneman calls the system one thinking, which is fast, hardwired, is based on extensive repetition, and is unconscious. We just come to things. And you've all done this every time. Yeah, you all drive to work, right? I'm thinking in Boston, most of us don't drive to work. You all drive to work, and you've gotten to work probably many mornings thinking, telling the kids to be quiet, or listen to the radio, or thinking about whatever you have to do as soon as you get there. And you get to work and you say to yourself, wow, I hope I didn't miss any lights or stop signs, because I don't even remember my trip to work. You were on autopilot. That's what we often call it, right? It's just intuitive. Now, some of you probably are old enough to have kids that you had to teach how to drive. Wasn't that a fun experience? Scary, yeah. Why is it scary? It's something we do automatically. They don't do it automatically. I have three sons. I have twin sons who are now 29, and I would take them out in 15 minutes of driving, and they would be exhausted. I mean, and we're talking about a parking lot. Because they have to make all these decisions. They do not have any intuition about driving because they don't have any experience. So they're in the analytical mode. They're thinking, how hard do I press down on the brake? They're asking me, how hard do I press down on the brake? Enough! Until you stop. They don't know that. It's a very slow process. It's very conscious. You are thinking hard, and you're trying to look forward and say, okay, so what am I supposed to do next? What am I supposed to do next? Instead of it being automatic. And that's the different types of thinking that we're talking about. And like I said, it's the flipping into knowing when to flip out of your normal mode and into this mode that is the tricky part. And then the not so tricky part is actually doing it. We're all pretty good at this when we choose to do it. We sometimes forget to choose to do it. So here, this is a schematic explaining Pat Crosscarry has done a lot of work. He's an emergency physician at Dalhousie University in Canada, and he talks a lot about this idea that we have the type 1, which is the intuitive based, and we have the type 2, which is the intellectual base. And what we do is we begin to see patients, and over time, just like now we're all experts at diagnosing cow, we develop patterns. At first we don't have any patterns, we have to figure everything out. But after a while, we start to recognize these patterns, and we have this intuitive process that is very fast, and we get to diagnoses very fast. We get it to immediately. In studying expert diagnosticians, if you ask them how you make a diagnosis, you just saw this patient, how did you make that diagnosis? They will give you some reason that usually is not the way they actually did it, because they did it automatically, and now they're just making it up. And say, well, I did this, and I noticed this, and I noticed. No, you didn't. You just did it. And that's a marker of the intuitive approach. Now we can have rational override and disrationality override. We can say there's sometimes where we're making these decisions, we're saying to the patient it's just like something else, and we say, okay, this is something, we're pretty sure what it is, and then there's something in the back of our mind saying, this doesn't quite fit. I don't know what it is, but it doesn't quite fit. And that's called the rational override, where we start saying, oh, I got to think about this. And then there is the disrationality override, when we're working real hard to think about things, and then despite what all the evidence tells us or what all the logic tells us, we do something else. This is I always think of this as the Captain Kirk, Mr. Spock dichotomy. You know, Mr. Spock was always coldly rational, type 2 thinker. And he, for those of you who've ever, it looks like most of you are old enough to remember Star Trek, he was always saying, you know, give her all you got. And Scotty's saying, no, I can't do that. And he says, give it all you got. That's because he's going more on some sort of intuition, which makes for good drama, but probably not good physics. So, but that's the idea. So that's the first part, is picking the right system. The second is to pick the best evidence. Now, the way we've been doing this is an evidence-based medicine approach, this idea that's about 20, 25 years old now. The way I think about it, that's sort of the basic science. It's like anatomy is, EBM is to anatomy as information mastery is to clinical practice. Information mastery, the stuff that I'm going to be talking about a little bit now, is sort of how do we apply evidence-based medicine in everyday practice. And it really is a focusing on underuse, overuse, and misuse to improve quality and therefore increase value. The third is to dampen down the biases that we all have. We have both cultural and implicit biases that we want to try to get control of. Now, here's another example. Again, lots of questions today. Steve is very shy and withdrawn, invariably helpful, but with very little interest in people. He has a need for order and structure and a passion for detail. It's most likely Steve is farmer. Anybody say farmer? Pharmacist? Disc jockey? Librarian? Member of Congress? Okay. All right. Now, imagine that there's a green alien in a ship, in a spaceship, and he sets down anywhere on Earth, you know, hovering around, all of a sudden sits down on Earth and gets out. Who is the first person he is most likely to meet? A farmer, a pharmacist, a disc jockey, a librarian, or a member of Congress? A farmer, right. So all of you who didn't say farmer, which is all of you, exhibited denominator neglect bias. Just on average, it doesn't matter what the specifics are, Steve is more likely to be a farmer because there are more farmers than all the rest of them. Again, not the way we normally think. We tend to, you were all coning down, right? You're thinking, well, I want to say pharmacist, but he's a pharmacist, I don't really want to embarrass him, so I'll say librarian, right? And disc jockeys, you're all thinking of Wolfman Jack, can't be that. But just probabilistically, there are many more farmers than there are librarians in the world. And that's called denominator neglect bias. We all do that unless we train ourselves out of it. Okay, so let's go back to this one. It should be easy now. According to traditional stories, how many antelopes did Moses take into the ark? 1, 2, 5, hold out, 5, 7, 14? Yeah, well, sorry. Moses wasn't anywhere near the ark. Boom. Another bias. Pattern recognition error. It looked just like the old question, except that it wasn't. Sorry, these little parlor tricks, but they're just to illustrate that we all do this. We all do this. Anyway, whoop, there he goes. Okay. We all do this. And the trick is to learn because it's fast, right? You looked at the question, you saw the picture, you saw the question, you didn't even listen to what I said, let alone read the top of it. So that's what happened. Now, better is possible. The first step is the self-awareness, is understanding how we think. And this would be called, in the educational world, would be called cognitive psychology, metacognition. It's understanding when we need to blink and just automatically do something and when we need to stop and think. And it's knowing that difference. If you do one all the time, it doesn't work. If you do the other one all the time, it doesn't work. And then the second is to manage our information. That's where some of the ideas that Dave and I have come up with come in. Now, this whole goal is about staying on the left-hand side here and not getting all academic about this. This is real world. This is not an academic exercise. It's not about reading more. It's actually about reading quite a bit less, but knowing what stuff to keep up with. And that's how, this is a conceptual equation. No more questions. No more things you have to figure out. This is just a conceptual equation that says that the usefulness of any source of information depends on three things: the relevance of the information, the validity of that information, and how much work it takes. So relevance and validity are on top because as they go up, usefulness goes up. Work's on the bottom. As work goes up, usefulness goes down. And the two are multiplied. So if we have highly relevant information that's not valid, it's not useful, or vice versa. So it's a very effective way of starting to get on top of the information that is available in medicine and ignoring almost all of it because it's not useful. So how do we do that? Well, let's look at the relevance of the information. And we can break the relevance. Some of you probably heard this before. We can break it into two big categories. Well, actually a very large category, which is called disease-oriented evidence, and a second category that I'll get to in a minute. Disease-oriented evidence tells us that what we do for people affects some blood level of something, affects some receptors, or affects some mechanism. This is all great stuff. We can't just make things up and hope that they work. We have to have some idea that what we do for people is going to affect the disease that they have in question. The issue is that we want to make sure that we don't just stop there. Instead, we want to go to what we call patient-oriented evidence. And this is the idea that what we do for people either makes them live longer, like this gentleman, or live better, like these people. Right? We all want to be doing this. We may not want to be doing that, but we want to be doing something like this as long as possible. People want to live long, pain-free, symptom-free, functional lives. And that's what they come in the door for. They say, because you're going to help me. And we have to convince them, you take this medicine, you do this thing, you let me do this thing to you, you let whatever, is because there's an implicit problem that they're going to live, or implicit promise that they're either going to live longer or live better. And that's what we're looking at for patient-oriented evidence. Now, what about the validity of the information? That's the second part of the usefulness equation. Well, this is where we differ from the sort of traditional evidence-based medicine approach, is you let somebody else do this. This is a journal club. You've all been in journal clubs. You've got one person in the front who's awake. Everybody else is trying to pretend like they're awake, but they're really not. Now, you're going to let somebody else do this part, but you're going to have to make sure they've done it right. So you have to teach learners what is the right way to do it, and then find systems, and there are plenty of these, that will do it for you. And then we can look at the one on the bottom, the work. And work, we can look at information sources themselves, and we can break them up into two big boxes. Again, what we call, this is like inventory management, just in case information sources. These are the Walmarts of information. These have everything that anybody wants. These are the PubMed, 6 to 8 million articles. Online textbooks, up to date. Plenty of information for everybody, just like a Walmart. The problem is it's difficult to get that information. On the other hand, we'll contrast that with what I call just-in-time information sources. Now, do you have 7-Elevens in this area of the country?
Come and go.
Come and go. Okay, shoo. Yeah. When I go to Canada, they have some other thing. I have to put the 7-Elevens of Canada. I'd put that up here. But the convenience stores, they don't have everything, but they have what most people need most of the time. And as a result, they're very low work. And we have information sources like this that don't have everything but what we need in clinical practice. So DynaMed is one of these, TRIP database. The second one, these are just some examples. If I were here for 2 days, we'd go into all of this. Essential Evidence Plus is a third. These have carefully packaged, highly synthesized information that you can get to quickly and get your problem solved. So that's the idea of usefulness. We want highly relevant information, patient-oriented evidence. We want it to be valid, but we want somebody else to do that validity assessment. And then we want to be able to get it very quickly when we need it. The biggest indicator of whether somebody in practice will look up something is their own impressions of their likelihood of finding the answer. If you don't think you'll find the answer, you won't look it up in the first place. So, and then this is yet another metaphor, lots of metaphors today, is this idea of knowing what we call the information mastery traffic light. This is an inventory management of your own information, your own knowledge, the own things that you do in everyday practice. And you should be able to say, well, there's some things I know based on good evidence that I should do for most people most of the time. There's some stuff that I know you shouldn't do for most people most of the time. Okay, those you can look up. Those we can figure out what is the information, and if it's based on high quality evidence, those are going to be stable. And then, but the biggest question is the yellow group, where we don't know where the benefit is compared with the risk. We have to remember, everything we do, every time we talk to a patient, every time we touch a patient, every time we prescribe something for a patient, every time we do a lab test, there is a risk of harm associated with that. And our goal is to make sure the benefit or the likelihood of benefit outweighs the risk of harm. And for a lot of things in medicine right now, they're in the yellow box. We're not sure if they're in the best interests of patients. Based on various levels of evidence, we think they might be, but we're not sure. So the inventory management comes up to saying, okay, what do I know for sure is a do not do? What do I know for sure is a do? And what do I not sure? Because this is where you can begin to be flexible, because if you know that what you're doing, you can't tell people to come back after the large randomized controlled trial is done and in 5 years from now. You have to treat them now with what you think is the best approach. But knowing that your best approach may be wrong puts it in the yellow box. And when it comes along and good quality evidence either moves it down here or moves it up to the red, then you can shift it into that. And this is just an information management system. So improving medical decisions involves a couple different things. This is learning the scripts. We are teaching students and then really into residency to learn the scripts, learn the medical scripts. This is what you do. You all know who teach residents. You know that residents, their ability to know why they move fairly quickly from thinking everything through, which is what was very successful to them as a medical student, into just tell me what to do. And they start learning the scripts. And that's what we do with System 1, and that's how you could recognize Ronald Reagan very quickly. That's in the diagnostic process, because then you automate things. Then we have to learn when to go off script. And this is when we have to think through and say, this patient doesn't quite fit the script that I normally use. There's something wrong. I got to figure out something different to do. Maybe I think about it for a period of time and I come right back to where I was, but at least we've stopped, gotten off script, and then went through System 2 thinking. Part of the ability to do that is being able to have information at the point of care where you can look it up. Lots of research done in this area. The average physician will take 59 seconds to look up an answer to a question. And that's the ones that they choose to look up. They don't think they can find the answer, they won't look up in the first place. So we want to be able to ensure that you have information sources that you can say, oh boy, Oh boy, I'm not sure this is right, but let me check, because I have this information source that I can da-da-da and find the answer very quickly. Then we want to be able to use that information to make decisions better. And the idea here is being comfortable, being confident with what you know, and knowing that what you don't know is not valuable. This was the title, Feeling Good About Not Knowing Everything, was the title of our first paper to explain the idea of information mastery, because a lot of information in medicine doesn't help us make clinical decisions. We also want to go the other way, and we want to avoid what we call the furrowed brow evidence-based medicine approach, where we get all real serious about it, and it's hard work, and then we don't do it the rest of our professional lives. Okay, so I'm going to finish there. I have some references, but that's the concept that I'm hoping is valuable to you. I can now take questions from here, or I don't suppose we can get them from distance, but maybe somebody's collecting those for us. Yes?
On the early chart where you had the simple, the complex, and the
Complicated?
complicated, and chaotic.
Mm-hmm.
If you had to take a guess at, say that represented 100% of practice, do you think, how much of that, I mean, what would the size of those areas
Right.
actually be?
So to me, especially in primary care, the complicated represents most of it. For example, if you look at the average patient with high cholesterol, most of them would not qualify for any of the trials that have shown that lowering cholesterol is effective in reducing mortality. Only 1 in 4 patients, typical patients who have cholesterol, high cholesterol, would have qualified for those trials. So we have to make the decision. Do these other 3 out of 4, do they still qualify? That's a complicated thing, because not only, because people with, say, for example, high cholesterol, they didn't have high blood pressure, they didn't have diabetes, they might have had cardiovascular disease, but they didn't have a lot of other things. But especially in primary care, you can't find a guideline that says, well, how do I treat this 52-year-old person with a history of cardiovascular disease who has prediabetes and has this and this and this and this? You can find guidelines for each individual thing, but not for that patient. And so that becomes a complicated case. So much of the stuff that we do, I don't want to rant about this, but most of what we do to look for pay for performance issues or quality measures, those are all process things. Those are all the low-lying fruit that probably don't affect anybody anyway. Yeah?
And then just to follow up on that, then, so given that the information you're looking for may not exist, how good do you think evidence sources are on identifying that the answer to the question you're looking for isn't available today? Because sometimes when people spend a lot of time looking, I think it's because of that.
And they throw up their hands at the end of it all. Yeah.
So,
Right.
so how well do they address, hey, what you're looking for doesn't exist?
So some people are trying to quantify that, and depending on what aspect of medicine we're talking about, maybe anywhere as low as, I've heard, or I've seen quotes as low as 12% and as high as 40% of medicine has data that's high quality, but a lot of it is low quality. And so there is a lot of move using, I don't have that slide, using strength of recommendation markers of some sort to say, we think guidelines are moving this direction to saying, we think you should do this, but it's a weak recommendation. So therefore, you can pull back and say, okay, so does it make sense in the context of this patient? And then use the last part of the RIDE idea of looking at the patient's preferences and talking with them and using shared decision making and saying, well, we could do this. There's not strong evidence it's effective. It might be, that's your preference. We can go that way. If not, we can go another way.
Is that what your slide that you showed, that DynaMed and that other script, whatever, as being the ready resources? There it is.
Yes.
How do those differ from the standard? I'm not familiar with those two.
So DynaMed tries to assemble all the world's literature on everything, but then distill it down into some way and come up with specific recommendations on what to do and tell you what the quality of that evidence is. So they do the validity assessment for you, and with varying degrees of success. I'm an editor at DynaMed. I'm an editor here as well. They try to meet two masters, both giving you all the information, but yet giving it to you in a way that if you just want the highlights, you can get them. And that's what that does. Trip database doesn't do that nearly as well, but what it does is assembles all the high quality evidence and gives it to you and lets you decide what you want to do. Yeah.
No, I just want to say that, so it puts it into evidence like A, B, C, D, and E.
Yeah, yeah.
That's all.
Yeah, there's all sorts of grading schemes like this, and there's an international move to get those just to one, so we don't have so many confusing guidelines or systems. Yeah.
Yeah, I'm just curious, you've been in this realm for 25 years or so now, and I mean, there's been such a huge shift in this direction with evidence-based medicine, and the tools are getting much more available and common. I mean, what do you predict for the future? Where is this going, and how do we prepare our what do we do in medical education to kind of take it to the next level or whatever?
Yeah, well, I think there are several moves afoot, if I can crystal ball this for a while. There was just a group that met in New Mexico maybe 3 weeks ago, and the title of the conference was called Beyond Flexner. And it was designed to say, let's move beyond the Flexnerian approach, the reductionistic Flexnerian approach that characterizes medical schools today, and move away from the idea. We have a group of students. We are well, I won't speak for all of us. A lot of us, some of us, me. I'm trying to think how to minimize the offense here. Most of us. Sorry, I am a digital immigrant. I grew up in a world where there wasn't computers. I had to learn. I had to immigrate into that realm. I have 3 sons who are digital natives, and I see some of you fresh-faced people are digital natives. You never knew a time when there wasn't computers. We are training people who are all digital natives, and they are constantly saying, in the rest of my life, I don't have to know anything because it's all on my cell phone. I can look it all up. Why are you cramming all this stuff into my brain, or trying to, when I can just look it up? If I think we're going to move, this Beyond Flexner idea was said exactly that. We need to get away from knowledge transfer in medical schools to knowledge processing, helping people make better decisions, rather than simply cramming them full of information that they're going to forget. And even if they don't forget, they shouldn't trust it, because it's probably wrong. Because the half-life of information is so short now. Yeah?
Yeah, but you mentioned earlier, most decisions are made intuitively speaking. You need to have the background in order to actually work in that system, particularly since they're only going to give a minute to look it up.
Mm-hmm.
And so it's important that the foundational knowledge be there, so the majority of the cases they can make that decision without having to look it up.
So
They're not going to.
So I would frame that just a slightly differently, and would say that the foundational knowledge helps them to see what they're seeing. But then after that, it is the constant repetition of practice and the coaching that we do. So I'm in resident education, so of course I think that's most important. It's the coaching that occurs to help them develop those illness scripts and perfect those illness scripts that we need to do. But the foundation, so I'll just give an example, because this is always on my mind. At a curriculum committee meeting at Tufts, about 2 years ago, there was a 20-minute discussion about why medical students needed to know what the isoelectric point was. Anybody know what the isoelectric point is? Got a couple nods. But in clinical practice, you never think about it. It may be foundational knowledge, it may not be. But that's the point, is we have to decide what is foundational knowledge. I gave you a lot of descriptors of cowness that didn't involve the actual, what do cows have, 4 stomachs, and I don't know, whatever. I just told you how to recognize a cow. We don't want to turn people into technicians, but we have to reevaluate how much information we're holding them accountable for. Krebs cycle, great thing. Don't use it in practice, for example. Yeah?
So what's your opinion of diagnostic software like Isabel, and is there any future for that kind of software?
Yeah, well, I think that's going to happen. I think there is going to be a lot of movement in their area, especially as those get more sophisticated. We'll probably move in that direction. We're already seeing it with diagnostic radiology and EKG reading and that sort of thing. I think those are going to become more. The idea of clinical decision support tools is really starting to take off. There's a huge government initiative to provide funding for people who are trying to develop clinical decision support systems. DynaMed is working hard to provide information at the point of care that would be helpful in people making decisions. But it's again, not having to recall it from your brain, but having some information source automatically pop this up, either before you know you need it or right as soon as you need it. You know, Google, the goal of Google is to provide you the answer before you know the question. Yeah?
So, given where you see the future heading, what thing in a standard medical curriculum that you see as being widespread now do you think will probably be cut in the next 10 years?
Well, I think a trimming of everything and saying, okay, let's just make sure that this matches up with what people are going to need to know in practice. So none of the actual coursework. It's just, can we start to link the clinical relevance to it with everything? I teach a course in evidence-based medicine in the spring of the first year to medical students, and it is the course is designed to set them up for the next course in the series, which is called Introduction to Clinical Reasoning. And it is the first course where they're introduced to uncertainty. And I say, I'm going to give you tests. I actually give them quizzes before. I use a team-based learning approach. You give them quizzes before every class, and I say, there are going to be 4 answers. 2 of them, sometimes 3 of them, could possibly be correct, but 1 is more correct than the others. Makes them insane. Because they've never done that before. I say, well, welcome to the real world. That's how it is. And I'm very gentle about it, but that's where, when they go to Introduction to Clinical Reasoning, it's all about measuring uncertainty. So I think saying, as we're building their basic science knowledge, we have clinical correlates to that all the time, so then it makes sense. It's that foundational stuff. But I don't know, that's where the Beyond Flexner group is going to work on, maybe giving us some guidance on what they think. But I certainly think it's going to be much more about how to make decisions and much less about acquiring the knowledge. Knowing that you need the knowledge is half of it. But being able to look it up is going to be obvious to everybody. Or clinical decision support systems that are going to automatically provide it to you. My crystal ball. Yeah?
So like, you said you were in residency education, and so you probably have experienced the fact that you're at the mercy of what we do in the preclinical years and the clinical years of undergraduate education, and we in turn are at the mercy of who we choose as applicants from undergraduate schools. Is that going to sort of slow this whole vision that you're seeing, or is it going to sort of accelerate it because students come in with 2 thumbs already working and stuff?
Yeah.
I've learned one thing is they are technically good sometimes, but they really don't know technology that well. So they know how to do things, but they don't understand things.
Yeah. Yeah. Because you're able to get away with it. As far as your question, I'm not sure that I know the answer to that. When you said that, it brought me back to about 10 years ago. Dave and I were in Cardiff, Wales, giving a 2-day course on this. And it's the funniest thing how these things happen. We were in a room over here, and over here there was a room of 6th grade teachers, or whatever the equivalent of 6th grade is in Wales. And these were teachers learning how to teach critical decision making to 12-year-olds. And we thought, wow, This is just fascinating how serendipity raises its head. They're teaching 12-year-olds how to make decisions. And we thought, wow, and we're teaching older people how to make decisions. Fascinating.
So maybe all ages will sort of move in a direction together.
I think so, and I think as the technology improves, this decision support will be more helpful. Nobody's really got a good handle on that, providing just the right information at the right time. Nobody's got, but there's at least a lot of movement toward that. Again, I could be completely wrong, but I just see. You know, have you ever seen the iWatch? Anybody have an iWatch? It is fascinating, the information it will give you about yourself. What time is it? Click it again. Your heart rate is well, mine's probably about 95 right now. This is a cheapo watch. This is not the iWatch. Everything. It's fascinating how much information is built into technology. My son, the techno geek, has reminders that tell him every hour if he's not up and moving. He works at a computer a lot. It says his phone goes off and says, "You haven't moved significantly in the last hour. Time to get up and move." If you can imagine it, it's happening. Okay. Anything else? We're running over a little bit. Yeah.
One question. If you were to start a medical school from scratch, how would you start?
First, I'd move it to the Caribbean. My friend Dave Slauson and I talk about this, and we said we call it Dave and Alan's most excellent medical school. And the first thing is it'd be in the Caribbean. I don't know. I don't think I have the skill or the chutzpah to say that I could develop a curriculum, a medical school curriculum, any better. I just know that we need to keep moving in a different direction. But that's just my predilection for everything, is that we need to improve. We need to improve and continually. Sort of my caveat is I don't have the answers, but I know what questions to ask, and I think that's my excuse. But it would definitely be warmer than Boston.
No snow.
No snow. Right. Yes.
Do you have a single source to leave us with for an introduction to sort of the topic of evidence-informed decision-making, if we sort of want to go to the next step?
Let me see if I have it on my last slide. Sorry. I can put in a little plug for something that I'm doing. My colleague that I keep mentioning, Dave Slauson, and I are putting together an online course to teach all of this to people. It's so much more efficient, both for the learner and the teacher, to teach online. Sorry, let me get to the end of this. I want to goof this up, bringing back all these bad memories. Sorry. I could have just selected the slides. Okay. Shoo! Okay, so here are a couple, and I'd be glad to leave this with you. Or if you just Google Tufts Information Mastery, to go to my website that has all sorts of stuff. But here are just a couple of things. This was remember that article, Feeling Good About Knowing? That's our first article. This is the second article we ever wrote. Still conceptually explain things fairly well. Mark A. Bell's article on how to find answers to clinical questions. It's a little out of date now, but close. And then Kahneman's book is very good, but it's 500 pages. So unless you really are interested in it, I wouldn't read that. There's some other medically oriented stuff by Pat Crossgray that's much more applicable. But just Tufts Information Mastery, you'll come to my stuff. All these are there for download. Okay, well, I want to thank everyone. I apologize, I went a little bit over. I want to thank everyone for your questions and interest, and for playing along with the questions and not getting too irritated with me, or at least outwardly. Thank you.